Welcome everyone. Thank you so much for joining. Tonight we will be talking with the expert panel from Vios Fertility Institute, and we're going to be covering miscarriage and recurrent pregnancy loss. So I'm Eloise. For those who don't know me, I'm the founder and CEO of Fertility Help Hub. I went through IVF myself in the States. My husband is infertile. He has Klinefelter syndrome, which makes him infertile. So we pursued IVF with donor sperm. The first round failed, and then we were lucky with the second round, and we now have 3 children thanks to donor sperm conception. And Fertility Help Hub encompasses everything I wish that we had had available, as well as community and expert knowledge and support for everyone, wherever you are in your fertility journey around the world. And I would love to introduce my guest tonight with Dr. Ree. Welcome.
Thank you. Thanks, Eloise. Hi, everybody. I'm Dr. Julie Ree. I am a reproductive endocrinologist and fertility specialist at Vios Fertility Institute in our St. Louis, Missouri region. Some of you may know, but Vios has multiple different offices, and I'm joined here today by one of my wonderful partners, Dr. Chanel Adams, who is from the Pacific Northwest region. We are so excited to be here, and Eloise, thank you so much for having us. We're really happy to partner up with Fertility Help Hub on this very, very important topic of recurrent pregnancy loss. Just a little bit about myself. I'm originally from the East Coast and grew up in Boston and ended up in St. Louis for some of my training, and I've absolutely loved it here being in the Midwest, and excited to talk to you guys tonight a little bit more, and happy to answer any questions you might have at the end of the session as well.
Thank you, and welcome, Dr. Adams.
Thank you so much for having me. I'm also very excited. As Dr. Ree said, I'm also a board-certified reproductive endocrinologist and infertility specialist. I am originally from the Pacific Northwest, so I'm actually from the state between Washington and California, so from Oregon, Portland, Oregon. I joined Vios at the beginning of this year, and I'll be a part of their new expansion because we have clinics in both the Illinois areas, mainly Chicago, as well as St. Louis, Milwaukee, and soon we'll have one in kind of the Washington State, Oregon State area, which I'll be in charge of. In terms of just my interest and a little bit about me, I've kind of been all over the United States, Oregon, Ohio, Illinois, Hawaii. So I kind of have a wide breadth of knowledge in terms of different types of patients and different types of care. Interesting thing you said, Eloise, about male infertility. It's actually one of my specialties, looking at the male component of fertility, because oftentimes it's underlooked and there's not a lot of good support or research about it. And in general, I do fertility preservation as well as oncofertility, patients that have cancer and fertility, cancer that affects their fertility. And really, as a person from kind of the West Coast, have a lot of information about kind of holistic and more mind body. So kind of marrying more of things that you can do that are not just meds with medications to be successful.
Fantastic. Thank you very much for those introductions. So I'm just going to move on to the next slide, if it will let me. Bear with me, sorry. Okay, so please tell us a bit more about Vios Fertility Institute.
Yeah, so I can start. We have multiple offices at Vios Fertility Institute. We have an office in St. Louis, Missouri, one in Chicago, Illinois, one in Milwaukee, and then one that is just opening in the Pacific Northwest in Portland with Dr. Adams. We have a couple of more that are opening as well. So, I would say that there are going to be many, many good fertility practices out there. What probably I would say sets us apart is that we focus on the patient experience. The patient is what's most important to us. We realize that not every fertility patient has the same background, has the same journey, and we really focus on individualized care. While we're doing that, I would say what's really important is that we also give very innovative care. So what that means is we are up to date on the latest science, data, and literature, but at the same time, again, keeping in mind where you have been and what you need. We also have outstanding results. So we report to the Society of Assisted Reproductive Technology in the US, where our IVF success rates are tracked. And I would say we have many, many babies that are born out of our offices. I would say that we also, probably very pertinent to our talk tonight, with I know some of you being in the UK, is that we have a global patient base. So part of Vios Fertility Institute's goal is not only to provide care to those in the US, but also globally.
Fantastic.
So first, we're going to just start off by going over some of the basic definitions. And the reason I think this is important is because you will hear many different definitions. What does a miscarriage actually, what constitutes a miscarriage? And furthermore, what constitutes recurrent miscarriages? Is it 2? Is it 3? Does it count if you have a positive pregnancy test at home and you never make it to an ultrasound? So it's important to look at these definitions, I think, so that we're all aligned, but at the same time, we recognize that, again, a positive pregnancy test is a miscarriage. And I think that that's what's most important as a reproductive endocrinologist. When a patient comes to me to say that they have this history of recurrent miscarriages, whether it was a positive pregnancy test at home or a positive finding on ultrasound, it's a miscarriage and it's devastating. And we realize that. So if you look at the definition, a miscarriage is a naturally occurring spontaneous loss of a pregnancy before the 20th week of gestation. So most full-term gestations are between 37 to 40 weeks. So anything that occurs before the 20th week is considered a miscarriage, technically. And if you look at the definition of recurrent pregnancy loss, you will see that many textbooks, many societies sort of have different definitions. But we usually go by the American Society of Reproductive Medicine's definition, or ASRM, which is kind of our governing body. And it basically expert guidelines that we follow. And RPL, or recurrent pregnancy loss, is defined as 2 or more clinical pregnancy losses. We looked into kind of where that definition came from. And what's interesting is sometimes societies will say 3 or more clinical losses, but what they have found is that the data suggests that if you've had 2 or more clinical pregnancy losses, or if you've had 3 or more, your risk of another miscarriage is pretty similar. So we usually start the workup after 2. Next slide. So what is the most common cause of loss? I think this is a really important fundamental concept to understand. Most patients, when they first come to us to say, hey, I've had 2 miscarriages or even 1 miscarriage, I think sometimes the hardest thing to do to realize is, what did I do wrong, or what did I do to cause this loss? Important take home here is that 60% of losses are due to abnormal chromosomes in the embryo. So what that means is that if the chromosomes in the embryo, each embryo should have 46 chromosomes. And if those chromosomes, if they're, misaligned, or there's an extra chromosome or a missing chromosome, or even if there's something wrong with the genes, on the chromosomes, you will have, your body is very smart and understands that likely it will not result in a healthy live birth, and therefore will result in a loss. So the other important take-home point here is that, the losses are related to the patient's age. So at less than 35 years old, there's about a 9 to 12% chance of a miscarriage. And that seems high, but the important thing there is that at baseline, there's always a risk of miscarriage. And that's also, your body's way of saying, hey, this is not a healthy embryo. Once you reach 35, a lot of us hear 35 as that threshold age of advanced maternal age where we get a little bit nervous. And at 35, that risk increases probably to a little bit higher, around 15 to 20%. And then at greater than 40 years old, there's about a 50 to up to 75% chance of loss. And this is really kind of related to the fact that as women get older, your eggs age. And as your eggs age, those chromosomes just kind of don't function the way that they should. So the DNA is a little bit older, and therefore the eggs being a little bit older, there's a higher chance of loss because of abnormal chromosomes in the resultant embryos.
So, as Dr. Reese said, we often start this evaluation after 2 losses. And so this testing is really kind of customized with the couple, but we also kind of look at your history. So we will ask, what kind of loss was it? Was it an early trimester one? How many weeks were you? Was it a chemical pregnancy, meaning that you potentially used a urine test versus a hormone test? Was it positive on the hormone test and went up? Did you ever have an ultrasound? But in general, approximately 50% of couples with recurrent pregnancy loss, we can kind of figure out a specific cause. But that still leaves half of individuals where we say everything really looks normal. We can't really denote exactly what the problem potentially can be, which, for I think both of us, we always are trying to find an answer. And also for couples, I know you always kind of want an answer. What is it? We always, again, do try to let people know it's nothing that you did. We are trying to find the answer. And if we can't find an answer or something to point to, there are different treatment options. So in general, when you think about the evaluation, it really does include things that potentially can affect your fertility, implantation, et cetera. So we start with things like your uterine cavity evaluation, because implantation happens inside the uterus. The other things we look at are just blood work, because we look at genetic causes. Is there an abnormality, as Dr. Reese said, with the actual embryo or with the parents that are creating the embryo? Is there a problem with hormone levels? Because hormone balances are very important for an appropriate egg, an embryo to be fertilized, and implantation. And also there's something that's called anti-phospholipid antibody syndrome, which we'll talk about a little bit later. Is there problems with this syndrome that can affect your losses or your ability to carry a pregnancy to term? So I'll kind of go a little bit more in depth in terms of a uterine cavity evaluation. So there's a couple things that you can do, or modes that you can look at a uterine cavity, and is it normal? One is something that's called a saline sonogram, or an SIS is kind of the acronym, which is saline infusion sonohistogram. It's typically done, in the middle of your cycle. So the best time is after you stop bleeding, usually between day 6 of your cycle and days 11, where a very, very small catheter is placed inside the uterus, and the uterus is filled with water. So the uterus is a potential space. So when you fill it with water, it kind of opens all the way up. So we can actually look at the actual inside of the cavity where implantation would happen. And we typically do this with a 2D ultrasound, but we also have the ability to do a 3D ultrasound with the water. We can actually create kind of the image of the uterus to look at all different points and say if there's anything on the inside that would affect implantation. Is there a defect? Is there a polyp? Is there a fibroid? Is there a change in the shape that makes it a little bit different? The other thing we can also do is something that's called a hysterosalpingogram, or an HSG. It's very similar to the saline. However, it is also done under X-ray. So basically it is a 2D picture. Again, it's during the same time of your cycle, kind of in the middle, where they put a catheter into the uterus and fill the uterus with dye. And then they use an X-ray to see the uterus. If you kind of compare the two, the saline actually is a little bit more sensitive and specific, because it truly is looking at the uterine cavity, and you can kind of zoom in and look at different aspects of the uterus. So in general, why is a uterine cavity important? Really, congenital uterine anomalies, meaning an abnormality in your uterus, which you're born with. And the thing is that oftentimes you don't have a symptom. The symptom is an inability to conceive, potentially losses, early preterm delivery. About 4.3% of the general population do have some abnormality in the uterus in which they were born with. But about 12.6 and up to 38% of people who have recurrent pregnancy loss, really, they were born with something that's abnormal about their uterus that, again, they would not have known about, except for this one symptom, which is likely either a loss or an inability to conceive. So let's go a little bit more into those uterine anomalies. So the ones that we really look at that can affect your ability to carry a pregnancy. The first one would be something that's called a septate uterus. So I'll make it really, try to basic it down as much as I can, but embryologically, the uterus is actually, developed by two tubes. They're called your Eulerian tubes. So they come in together and they fuse. Once they fuse, they're supposed to resorb or hollow out. So your uterus is a hollow tube. One thing that can happen is that hollowing out, or that resorption part, doesn't happen. So there's a little division on the inside of your uterus. That division is called a septum. It typically is greater than 1.5 centimeters from the top of the uterine cavity. When you have a septum inside the uterus, it does increase your risk of a loss. And the reason why, or the thought process is, if you have an embryo that implants on that, it's not very thick like the rest of your muscle. There's not really good blood flow. So therefore it can lead to loss even though there was implantation. Other things are potentially adhesions, syncytials, scarring that is within the uterus. Now that can happen for a couple reasons. The most common thing are individuals who have actually had losses in the past, or have had manipulation of the uterus because they had heavy bleeding, polyps, etc. When you kind of scrape the inside of the uterus, like multiple parts of your body, when you get a cut on your hand, you could actually try to heal it. But when your body tries to heal it, it kind of makes a thick scar. A scar is a fibrous area. Again, it's an area that kind of holds things together, and it doesn't have really good blood flow. So if you have adhesions, whether it's mild ones or true Asherman's where you have a lot of scarring or closing of the uterus. Again, there's not parts of your uterine lining or your endometrium where an embryo can implant good blood flow and kind of set itself up. The last one is a bicornuate uterus. Now, a bicornuate uterus is kind of, again, a mixture of the two when I think about embryology. There's a problem about fusing all the way and a problem with resorption. Again, the thought process is similar to the septum, but it is also a little bit, it's more associated with kind of preterm birth or labor, because you're kind of dealing with kind of half of a uterine cavity. It's like one horn, the right versus the left. Next slide, please. So beyond looking at the uterine cavity before, as I said before, we do additional blood tests that we look for that can affect a lost. And one of those things is looking at the genetics. As Dr. Reese said, it's the most common cause of a lost. So we do a blood test on both the mother and the father, maternal and paternal, to see, is there any abnormality in your chromosomes? To be, a genetic woman, you have a balanced chromosome set of 46XX. To be a male, you are 46XY. When you create an embryo, mom gives half of her genetics and dad gives half of his genetics. However, if there's a problem with your genetics or your chromosomes, I always tell people to think about their chromosomes like the library. You have all the books to tell you who you're supposed to be. But some of your books, if they're out of place, when you divide it in half, you can't make a true library, meaning that you can have what's called a balanced translocation. You have all your chromosomal information, but one piece or one chromosome could have broken off and moved to a different one. So when you divide things in half, again, like I said before, as it comes from mom or dad, you don't have that balanced number of chromosomes, and that can lead to abnormal embryos, unbalanced chromosomes, which can lead to miscarriage. Next slide, please.
Great. So I'm going to delve a little bit into anti-phospholipid antibody testing. So when you come in and tell us that, you've had a couple of miscarriages, we'll take your history, obviously, and then we'll delve into, okay, what testing can be done. So like Dr. Adams said, definitely the uterine cavity is so important because it is the cavity where that houses the embryo or the growing fetus. And so she talked about that. Now, we also will recommend that we do some blood work. And I'll talk a little bit about what type of blood work that entails. So there's something called APLS syndrome, or anti-phospholipid antibody syndrome. It is very rare. So I will start off by saying, when we delve into this type of testing, you're kind of looking for sort of the zebras, right? Like not the common things, but you're going a little bit beyond that. So between 5 to 20% of patients with recurrent pregnancy loss will actually test positive for this syndrome called APLS. And the range is really high. I would say anecdotally, I probably see it closer to that 5%. And actually, the American Society of Reproductive Medicine says it's about 5 to 7%. So it's pretty low. But if you find it, the great thing is that there's treatment for it. So the tests that the blood test looks at, it looks for 3 different types of antibodies. One is called lupus anticoagulant. Another is called anti-cardiolipin antibody, and another is called anti-beta-2 glycoprotein. So it's kind of a mouthful, and you're probably not going to remember all of these terms, but just APLS testing is what you need to remember or ask about. And what it is these antibodies, if you have these antibodies in your blood, they actually can interfere with implantation. The way in which they can interfere is when that embryo, if you have a perfect embryo, even if it's, let's say, chromosomally normal, and you've got a perfect uterus, there are so many detailed things that need to happen at that interface between the uterus and the embryo for implantation to happen. And so, that's kind of also how the placenta is eventually formed, at 8, 9, 10 weeks. And the placenta, as you know, is really important for blood flow to the baby. So these anti-phospholipid antibodies can actually interfere at that interface and cause very small blood clots and cause whatever normally should happen for normal placentation to happen to not happen. Next slide. So again, what are the effects? It can inhibit placental invasion. It can cause apoptosis or just kind of the killing of placental cells. And so the placenta doesn't grow and there's no blood flow to the growing embryo or then fetus. Initiation of maternal inflammation, which can lead to clotting in the very small blood vessels that are there, or microclots. This is why women with APLS syndrome, even if they do make it past that initial phase of embryo implantation, you can also have placental insufficiency that results in preterm delivery, preterm labor. So where that embryo implants really early on in gestation is so important for the rest of the pregnancy, and it almost like sets the stage for the pregnancy. If you are found to have any of these antibodies in your blood, the treatment for it is to take low dose or baby aspirin, so 81 milligrams, as well as heparin or Lovenox, which are injectable blood thinners. And there's really good data to show that treatment with these blood thinners can really improve outcome. Next slide. So other considerations for recurrent pregnancy loss, and the ones that are on this slide here are a little bit more controversial, for lack of better words, meaning there isn't very, very clear data on this. So these are some things that your doctor may or may not recommend. And I can certainly tell you what the ASRM recommends and what we do here at Vios. So endometritis is chronic inflammation of your uterine lining. So the uterine lining, as you know, every month, that you ovulate, before you ovulate, the uterine lining thickens, and then you ovulate, you release progesterone. Progesterone then thins out the lining. If you're not, once you're not pregnant, it sheds because the progesterone from the corpus luteum, which is the follicle that you ovulated from, regresses and it dies off. Now, the uterine lining is such an important part. So not only is the shape important, like Dr. Adams was saying, but the actual lining is important. And inflammation is something that's very vague and very hard to test for. But when a woman is, miscarrying over and over again, and you can't find other causes, one reasonable option is to do an endometrial biopsy, where you take a very small sterile pipelle and you go up into the uterus under ultrasound guidance sometimes, and we'll take a very small sample of the tissue at the top of the uterus and we send it off for pathology. And that pathology specimen will tell us whether there's underlying inflammation. There's good data to show improved outcomes if there is inflammation and it's treated. And I think the data on whether it improves live birth rate, though, is pretty equivocal. So that's why it's a little controversial there. The second thing is natural killer cells. So natural killer cells, I would say, are pretty controversial in the sense that not everybody tests for these. And so we don't necessarily do this throughout all of the Vios offices, but basically natural killer cells are part of your immune cells, and you will have them in your bloodstream and you will also have them in your uterus. And they're actually a very important part of implantation. So there's a theory that if your natural killer cells are too high, potentially you may need treatment to decrease your risk of miscarriage. And the treatment for that is to give intralipid infusions. But I would say that this one's a little more controversial. The American Society of Reproductive Medicine still says that there isn't very clear data on this. And then thrombophilias. So thrombophilias are blood clotting disorders. So many, many years ago, we used to think that blood clotting disorders such as factor V Leiden, prothrombin gene mutation, antithrombin, as you can see on the slide, and protein C and S deficiencies actually caused miscarriage. And since then, I would say that theory's been debunked. So, if you're coming in for recurrent pregnancy loss workup, we don't immediately jump to these. If you do have a family history or a personal history of a blood clot, this would have potential implications for pregnancy, in which case you might want to be on blood thinners in pregnancy. So again, we don't necessarily jump to doing these. But having said that, I will say, like I said at the beginning of the webinar, a lot of this is so personal, and sometimes you've done everything and you still miscarry, and we really are just searching for answers. So these are some things that your doctor may recommend. I think this is you, Chanel.
Yeah, so treatment options. So as Dr. Reese said before, we tailor your treatment options based on if we can find a cause. So obviously, when we talk about the uterine cavity, if we find things like a septum, or if there's asherment or those scarring or adhesions in the uterus, you can actually have surgical correction of that. So that typically is done with a hysteroscope, where you basically can do them either in the operating room or in the office. Here at Vios, we actually have a surgical suite in our office, so we do the procedures here, where you basically go into the uterus with a hysteroscope. you expand the uterus with water and able to actually identify these abnormalities. And basically either under ultrasound guidance or some people do laparoscopic guidance, you're able to actually resect or cut the septum, because once you cut the septum away, the uterus can open up. If there are adhesions, same thing, you can cut those adhesions out of the uterus. After the uterus, it kind of depends on who you ask. It does vary. There's not direct one-to-one on which is the best, but you can consider additional things after you remove either the septum, depending on how big it is, or the adhesions, depending on how extensive they are. You can add or put the patient on estrogen, which again helps the lining to rebuild and heal itself, which can be for 1 or 2 months. Some people also will put in a mechanical barrier, such as a balloon, because they want the uterus to be open as it's healing and they don't want it to re-scar down. As Dr. Reese said before, if we can actually find some inflammation, you can treat that inflammation or infection with a course of antibiotics, and then retest afterwards with a biopsy to make sure that it's actually been treated. If we find out it's kind of potentially some hormonal problems, problems with prolactin, which is a hormone that comes from the brain, insulin or glucose intolerance, if you have diabetes, treating these hormonal abnormalities can actually put you into more of an optimal area for being carrying a pregnancy to term. And then as Dr. Reese said before, things like heparin or Lovenox are used for anti-phospholipid antibody syndrome. If you do find out that you actually have a balanced translocation, some kind of genetic cause for all your losses, you can do IVF. The nice thing about IVF is that we can create embryos, and within the lab, we can do something that's called PGTA, which is pre-implantation genetic testing, where when you create the embryos, or what are called advanced embryos or blastocysts, where you can actually distinguish or denote the difference between the fetal tissue in your embryo and the placental tissue of your embryo. You can actually, on the days 5, 6, or 7 after creation, identify the trophectoderm, which is your outer cell embryo, which is the little cells, and you can pull off about 3 to 8 of those. Then you can freeze your embryos, and that tissue can go to a genetics lab, and there's various ones throughout the country in the United States. They're able to actually amplify that DNA and do a karyotype. So you can actually look at the embryos that you've created and find out, does this have a balanced number of chromosomes? Is there a genetic or chromosomal abnormality that's causing the loss? So you're putting in the normal or euploid embryos at the appropriate time. In terms of other treatment options, this is a very complex thing. Again, like we said, there 50%, we don't really know why. We don't have a direct cause. So you want to optimize your health in order to decrease your likelihood of having a loss. So smoking is something that's very difficult to quit if you're doing it, but it's for a great cause. Smoking can definitely affect your fertility. They actually have done studies that women who smoke every single day go through menopause earlier. So there's something about those free radicals when you're smoking that can affect the quality of your eggs. Likewise, when you're overweight or obese, obesity is actually a risk factor. They look at women who have BMIs greater than 30 and 35, and they can have a 2 to 3-fold increase in losses. So, if you have a high BMI, losing weight sometimes can increase your likelihood of actually carrying a baby to term, because that could have been one of the causes. And the last thing is kind of like the psychological thing. As I said before, it's the whole patient. So having actually psychological support and close monitoring. There actually have been tests, it's kind of like a TLC type thing, that individuals who have loss, having frequent or weekly blood work and an ultrasound confirming that, yes, everything is okay. The baby is growing appropriately. The heartbeat is appropriate. Actually can do better if they do that throughout the first trimester. So oftentimes within our office, if we have a person who has recurrent pregnancy loss, we will see them weekly until they're past the time that they actually had their loss, or at least up to 12 weeks when they're past the first trimester. Next slide, please.
Great. I know we covered a lot here, but we thought we'd just, sum up a couple of the key points. Here's the good news about recurrent pregnancy loss. So, if you don't remember anything from this webinar, I would say I would hope that you would remember this. The prognosis for couples with recurrent pregnancy loss is encouraging. The overall live birth rate is about 70 to 80%. So they have actually done studies, and you will see the chart here on the right side of the screen, where they've looked to say, in couples who have had up to 5 prior losses, their chances of having a baby is still about 70%. And this is true for patients with a specific diagnosis, as well as those with unexplained recurrent pregnancy loss. Although this data is very encouraging, we still encourage you to seek help from a fertility specialist, because, we realize that you don't want to have 5 to 6 losses before you have a healthy baby. And especially if you're older, this has implications about future family planning as well. So this data is not here to say you should wait. You should seek help after at least 2, but that the prognosis is overall really good, which is the positive news. And so, as we had said earlier, Vios Fertility Institute is committed to assisting patients in finding treatable causes of RPL. So, 50% of the time we do find a cause, and it's great because we can help you with that treatment. And then personalized treatment, even in unexplained recurrent pregnancy loss cases. So you might be thinking, well, what can you do for patients where you don't find a cause? There are many things we can do. So there's also something, we didn't talk about it in this slideshow, but there's something called empiric therapy, which means empiric treatment means there may not be good data to suggest improved outcomes, but we can certainly help to prevent another loss. And those are things like baby aspirin, which you've heard of, higher doses of folate, luteal phase progesterone, which I think someone sent a question about. So these are all other types of things that you can do, even if you don't find a reason for why you keep miscarrying. And then again, evidence-based treatment options specific for each individual. Another take-home point here is that we give individualized care. And I think that's so important because, like Dr. Adams was saying, there's really good data to show that patients with recurrent pregnancy loss do better when they're given individualized care and they're seen more frequently in the office. And there's definitely something to be said for there being a psychological component to that as well.
Insightful. I hope that it has been for everyone who's joined us live tonight. I'm sure it has. And as I mentioned before, the contact details are there if you would like to reach out and have a personal conversation and consultation. So thank you so much to everyone who's joined this evening, and thank you to you both for taking time out to do this.
You're very welcome.
You're welcome.
Bye-bye.